The last learning objective is given a patient living with HIV who is infected with an opportunistic infection, recommend guideline-concordant treatment. So for PCP treatment, obviously it's important to start the patient on ART to get the CD4 count up. And then for the actual treatment of PCP, you have to look at the severity. So for mild to moderate, and the criteria are listed here for mild to moderate, you typically use an oral treatment. And again, treatment of choice is Bactrim, so trimsulfa, 15 to 20 milligram. And this dosing is based on the trimethoprim component. So when we say 15 to 20 milligram per kilo per day, that's basically trimethoprim, and then whatever sulfamethoxazole to match it when it comes in the pill. And that's, so when you calculate 15 to 20 milligram per day, that's the total daily dose. You want to break it into 3 divided doses. And then you treat the patient for 21 days. And obviously, if they cannot tolerate trimsulfa, you have some alternatives. So dapsone plus trimethoprim, because the sulfamethoxazole typically causes the skin reaction. So if someone cannot tolerate that part, it can also be nephrotoxic. You can give the trimethoprim alone with dapsone. You also have primaquine plus clindamycin. And lastly, atovaquone. So atovaquone for prophylaxis is okay, but when it comes to treatment, is an absolute last line, because it is been shown in studies to be less effective. So you really want to avoid atovaquone for treatment if you can. It's only your last option. And then when it comes to moderate to severe, you obviously want to, if you can, you should use IV treatment. So Bactrim is available as IV, so you can use IV Bactrim. If someone cannot tolerate IV Bactrim, then you have some alternatives. Primaquine obviously is only available as oral, so you have no choice but to give it oral if someone couldn't tolerate pentamidine IV or Bactrim. And for these patients who either the PO2 is less than 70 or the gradient is more than 35, so alveolar and arterial oxygen gradient is greater than 35, these patients also need prednisone. So this is adjunctive. So in addition to what you're giving for treatment, so if you're giving Bactrim, these patients, in addition, they also need prednisone for 21 days. And here's the dosing taper recommendation. And that's because this addition of prednisone has been shown to reduce mortality. So for that reason, someone has moderate to severe PCP, you have to give them prednisone. Or if prednisone is not available, you do an equivalent corticosteroid. And then once you finish treatment, the question is, do you need to prevent this from happening again? So there is such thing as PCP secondary prophylaxis. So you basically give the same agents we use for primary prophylaxis, and you continue it until the CD4 count is greater than 200 for at least 3 months. For Toxoplasma gondii encephalitis, the treatment is a combination of pyrimethamine, sulfadiazine, and leucovorin. That's the preferred agent. And you want to treat for at least 6 weeks. So this is a 6-week treatment. And even longer duration if clinical or radiologic disease is extensive or response is incomplete at 6 weeks. So you have to monitor the patient through the 6 weeks and see how they're improving. And then once you finish the treatment, you just continue the same treatment as chronic maintenance therapy, or you can also call this secondary prophylaxis. You just keep continuing the treatment until the patient, not only asymptomatic, but you want to make sure the CD4 is more than 200 for at least 6 months. And for disseminated MAC, basically the preferred agent for treatment is combination of clarithromycin with ethambutol. We will discuss ethambutol more when we talk about tuberculosis, but you want at least 2 agents. And many experts also add a 3rd or 4th agent if the mycobacterial load is more than 2 log CFU per ml of blood, or if the patient is not on ART, so you need a 3rd or a 4th agent. And the 3rd and a 4th agent would be rifabutin. This RFB is the shorthand for rifabutin. And you can also use fluoroquinolones, specifically levofloxacin or moxifloxacin, not ciprofloxacin. You can also have the option to use an injectable aminoglycoside. So amikacin and streptomycins are the ones that are typically used, not really gentamicin or tobramycin. The evidence is with amikacin or streptomycin. And then the treatment for MAC is at least 12 months. And then once you finish treatment, you just continue for secondary prophylaxis, or you can call it chronic maintenance therapy, until not only the patient is asymptomatic, but you want to make sure the CD4 is greater than 100 for at least 6 months. This concludes this presentation.